Sorry for the interruption of this lecture due to the internet issue. So I'm going to resume my talk from where I left the last talk. The disease I'm going to discuss now is Yaws. Yaws is a disease that is caused by a spirochete, Treponema pallidum pertinue. And it is considered to be among the neglected tropical diseases by WHO. And the disease is endemic in tropical rural population of Caribbean, Central and Southern America, tropical Africa, Southeast Asia, and the Pacific Islands. The transmission is favored by overcrowding. It was among the commonest tropical diseases of the region from 1950 to 1960. But now it is no more the commonest tropical disease because of the extensive treatment campaign by WHO. Failure to eliminate the disease is probably related to difficulty in managing the latent phase in remote areas. The disease is commonest among children, and both genders are affected. Clinical feature. There is seldom a history of injury preceding the appearance of initial lesion. The primary stage is called as the mother yaw, is a solitary erythematous papule, although multiple lesions sometimes occur at the point of entry of the treponeme. This lesion later ulcerate and covered with a yellow crust. It subsequently increase in size to resemble a raspberry, hence another name of framboisia, which is teeming with treponemes. The mother yaws last for 2 to 6 months and heal spontaneously and leave an atrophic scar. This is the mother yaw or a primary yaw. Then the secondary stage, which is called as the daughter yaw, and it is characterized by multiple papule, plaque, or ulcer that develop in successive crops adjacent to body orifices. They are highly infectious. The late or the tertiary stage occur after several years and is seen in 10% of patients and present with nodular or tuberous lesions, which is known as the gummatous framboides. Palmoplantar keratoderma, juxta-articular nodes, gangrenosa, which is deforming rhinopharyngitis, producing mutilation of the nose, periostitis and ostitis, mainly of long bone, which give rise to the saber tibia. So these are the secondary yaws or the daughter yaws or the secondary stage, in which multiple papules and ulcers are distributed on the body. Usually takes 2 to 4 months. If a biopsy is taken, then and Wharton starry stain is used, numerous spirochetes are seen around the blood vessels, at the tip of dermal papillae and in the epidermis. Investigations. As the organisms of yaws are closely related to syphilis, the serological tests of syphilis are also employed in yaws. Biopsy is not confirmatory diagnostic procedure. There is dense inflammatory infiltrate consisting of plasma cells. And if Wharton starry stain is used, then numerous treponemes can be identified. Management similar to syphilis is by intramuscular benzathine penicillin, which is a long-acting penicillin, 1.2 million unit for adults and 0.6 million unit for children. Oral treatment including penicillin V or doxycycline is effective in small studies. Recently, WHO is promoting use of azithromycin as the principal treatment, as it is simpler to administer to a large scale to both patients and community contact. This is an effort to eradicate the disease in endemic areas. Pinta, again a disease caused by spirochete Treponema pallidum subspecies Caritium. The disease is endemic in remote areas of southern Mexico and central southern America. Histopathology shows lichenoid changes, numerous melanophages in upper dermis. In hypopigmented lesions, there is epidermal atrophy as well. Treponemes are demonstrated in lesions in all stages. Again, like the endemic syphilis and the Yaws, the disease has primary, secondary, and late stage. In primary stage, a few papules or erythematous plaque develop, and after an interval of months or years, the secondary stage occurs. And it features extensive lesions, which are similar in appearance to the initial lesions. And these lesions are known as the pintids. Their initial red color changes to brown, slate blue, or black. And eventually, patients enter the late stage. Late stage is the depigmentation intermixed with hyperpigmentation. Atrophy is a rule. Secondary and primary stages are infectious, but late stage is not. So this is the primary stage. And these are the hypopigmented and hyperpigmented lesions in the late stage. Differential diagnosis is erythema dyschromicum persistens, pityriasis alba, vitiligo, atrophic lichen planus, and tuberculous leprosy, all in the late stage. Investigation. The diagnosis is similar to that used in Yaws with dependence on serology. And as with other treponemes, the treatment is penicillin as the first line therapy. Relapsing fever. The relapsing fever is not primarily a dermatological condition. However, it is associated with a skin rash. And there are two forms of relapsing fever, a louse-borne or epidemic relapsing fever due to Borrelia recurrentis, transmitted by human body louse, and a tick-borne endemic relapsing fever caused by Borrelia dutoni and Borrelia hermis. So Borrelia recurrentis, Borrelia dutoni, and Borrelia hermis, characterized by high fever, malaise, headache, vomiting, respiratory symptoms, jaundice, hepatosplenomegaly, and liver tenderness. There may be a petechial or purpuric rash predominantly on trunk in up to 60% of patients. Remission occurs after a few days, which is followed by relapse, and this pattern continues for weeks. The cutaneous eruption does not, however, recur after initial episode. Diagnosis: best confirmation by demonstration of the spirochete in blood film using stain preparation or dark ground illumination. Usual treatment is tetracycline or erythromycin. Penicillin is an alternate because treatment failures are more frequent in tick-borne group. The course of therapy is usually 10 days. Lyme disease. Lyme disease is also a spirochetal disease. It's a tick-borne zoonotic infection caused by Borrelia burgdorferi. The characteristic eruption, erythema chronicum migrans, is at the start of inoculation, and dissemination of infection may cause disease of nervous system, heart, and joints, in addition to other dermatoses which occur later. Patients usually live close to or have visited the woodland areas where small mammals are the necessary host for the immature stages in life cycle of the tick. The adult exotic tick may infest large mammals, especially the deer, any age, both gender. Clinical feature: 50% recall a tick bite, and 90% of patients with a bite develop erythema chronicum migrans at the site of inoculation. The eruption appears 1 to 36 days or average 9 days after a bite and is due to the local spread of spirochete in a ring form. In older lesions, erythema become dusky blue. Moderate burning or itching occur. If untreated, the lesion fades, usually within a few weeks. Renal lymphadenopathy and mild constitutional symptoms may also occur. The dissemination of infection occurs within days or week of inoculation, and now spirochetes are detected in the affected organs. 7% of the patient develop arthritis. 18% have a neural involvement like meningitis, cranial nerve palsies, or peripheral radiculoneuritis, and 10% have heart disease. This is erythema chronicum migrans characterized by annular erythematous lesion around the site of a tick bite. Another image. If we do histology, the histology is that of mainly perivascular lymphohistiocytic infiltrate in both superficial and deep dermal blood vessels in a coat sleeve pattern. And the infiltrate is comprising of lymphocytes, histocytes, and sometimes neutrophils and eosinophils, like an insect bite reaction. The second dermatological manifestation of the condition is lymphadenosis benigna cutis that develops near the site of original erythema chronicum migrans, mainly on ear or on breast areola. Borrelia burgdorferi, serology is usually positive, and the lesions subside within 5 weeks of antibiotic therapy. This is lymphadenosis benigna cutis. The third dermatological manifestation is acrodermatitis chronica atrophicans. It's a late cutaneous manifestation. Eruption develops 1 or more years after the original infection. Typical site is hand, feet, knees, and elbows. Lesion begin as erythematous plaque which become violaceous and atrophic. Borrelia burgdorferi serology is positive in all cases, and the lesion respond to appropriate antibiotic therapy. This is acrodermatitis chronicus atrophicans, present as red or violaceous atrophic plaque. Histology is characterized by thinned epidermis, a lichenoid infiltrate without, that is a band-like infiltrate but no interface change, plus superficial and deep perivascular lymphohistiocytic infiltrate. So infiltrate is predominantly lymphocytic and plasmacytic plasma cells. They are thick collagen bundles. So the clues of diagnosis of acrodermatitis chronica atrophicans is a lichenoid arrangement of infiltrate in upper dermis, epidermal atrophy but no interface change, and thick collagen bundles. Nevertheless, the diagnosis should be confirmed by identifying spirochetes with silver stain or by PCR. Management. Patient with suspicious skin lesions should be treated while putting in place the appropriate investigation. Patient with a solitary lesion of erythema chronicum migrans respond to oral doxycycline 100 mg 2 or 3 times a day, or amoxicillin 500 to 1 gram 3 times a day. A 14 or 21 day course is suggested. cefuroxime or erythromycin or alternates, after the dissemination occur, result of even intensive therapy is less impressive. Mild systemic diseases is treated as above, but severe cases require intravenous treatment. Now, ceftriaxone 2 gram daily IV for 2 weeks seems the best. Benzyl penicillin 2.4 million mega units daily for 2 to 3 weeks is also useful. Botromycosis. Botromycosis is a chronic granulomatous reaction to bacterial infection containing granules that resemble the sulfur granules of actinomycosis. Most cases of botromycosis are caused by Staph aureus, but in some cases, Pseudomonas is also isolated. A rare condition with sporadic worldwide distribution, any age and both genders, associated with diabetes and AIDS. A history of injury is common, and a size of bacterial inoculum may be crucial, and a delicate balance between the host and pathogen has been regarded as significant. Clinically, it resembles actinomycosis. Most lesions are on the limbs, but perianal region and face is also affected. In primary cutaneous form, single or multiple abscesses of the skin or subcutaneous tissue break down to form discharging serous fluid and multiple sinuses. After healing, after many months, it leaves a trophic scar. The general condition of patients remain good. Differential diagnosis is mycetoma and actinomycosis and frunculosis. The condition, the Botromycosis looks very similar to actinomycosis and mycetoma. Clinically, Botromycosis is characterized by a chronic suppurative nodule, and there is the suppuration is surrounding the typical bacterial colonies, and there may be sinus formation and fibrosis. The bacterial colony is most common. Have a very similar look to the colony of actinomycosis, and in addition to staph, Pseudomonas, Proteus, E. coli, and Streptococci are also seen. If we do the granules, the colonies are characterized by non-filamentous bacteria in a hyaline matrix containing IgG and C3. So it is called as the Splendor-Hoppeli phenomena. The first line treatment is flucloxacillin or erythromycin as usual, and second line or alternate treatment is flucloxacillin with fusidic acid. Response is often determined by presence or absence of usually a pre-existing or predisposing disease. Necrotizing subcutaneous infections. This is a group of infections in which the principal focus of the disease lies within the soft tissue or the epidermis, adipose tissue, and subcutaneous fascia, where the hallmark of infection is extensive necrosis accompanying cellulitis. Synonyms and inclusions: the necrotizing fasciitis, Fournier's gangrene, progressive bacterial synergistic gangrene, Melanie gangrene. Affected patients are usually severely ill and toxic, with mortality of up to 45%. Rare in children and either gender. Predisposing factor: trauma, infection, diabetes, and previous surgeries. It is suggested that infection is caused by beta hemolytic group A streptococci and multiple other anaerobes. Following are the proposed types: Clostridial cellulitis, Milanese necrotizing cellulitis or fasciitis due to strep, progressive bacterial synergistic gangrene, gangrenous cellulitis due to Pseudomonas or mycete fungi mucormycosis, the Fournier gangrene, cellulitic necrotizing process that originally affect the lower abdominal wall and scrotal fascia. This is Melanie's synergistic gangrene. Clinical hallmark of all these infections is appearance of necrosis in addition to cellulitis, often accompanied by rapid course and considerable toxemia. They are part of continuum of disease from cellulitis to myonecrosis. Death is the frequent outcome in such cases. Patients usually present with hot, tender, erythematous area of swelling and dusky. Bully and necrosis of underlying tissue may supervene. Unfortunately, most onset may be indolent, giving rise to a false sense of lack of urgency. Most important step in diagnosis and management is surgical exploration, in which subcutaneous tissue down to fascia are found to be necrotic and contain clumps of gram-positive bacilli, and these tissue need to be excised. Differential diagnosis is gas gangrene, mucormycosis, cellulitis, Pyoderma gangrenosum, and ecthyma gangrenosum. Complications are deep invasion with progressive necrosis and infarction of subcutaneous tissue, toxemia and septicemia, and disease is fatal unless treated. Diagnosing the organism should not delay the therapy, which consists of surgical debridement of infected tissue immediately. And treatment is by intravenous penicillin G in high dose. Metronidazole is used in addition. Heparinization should be used to control DIC. Chlamydia. Chlamydia are obligate intracellular parasites, but in their infectious form, they have a cell wall that contain both DNA and RNA and replicate by fission and are susceptible to broad spectrum antibiotics, notably tetracyclines, and are therefore classed with bacteria. There is a single genus with two subgroups of species. Chlamydia trachomatis is classified into 15 serotypes. Type A, BA, B, C cause trachoma, which is a frequent cause of blindness. Type D to K are sexually transmitted and cause chlamydial urethritis. Type L1, L2, and L3 is against sexually transmitted, affect lymphatic tissue and cause a disease that is called as lymphogranuloma venereum. Chlamydia psittaci is a group B infection causing interstitial pneumonitis known as the psittacosis or ornithosis. Rickettsial infection. Rickettsia are regarded as small bacteria which are obligate intracellular parasite and spread by bites of blood-sucking arthropods and cause widespread infection in endothelial cells that result in vascular infarct, extravascular fluid loss, and DIC. Rickettsia are classified into 5 main groups on clinical and serological grounds. Direct or indirect immunofluorescence, Western blot, and PCR diagnostic tests are available depending on the disease, but treatment should be started on the basis of the clinical diagnosis. Epidemic typhus, caused by Rickettsial provoski and transmitted by body louse. Humans are the only reservoir of infection, any age, both sexes. There is multiplication of Rickettsial in endothelial cells of small blood vessels, leading to obstruction, thrombosis, hemorrhage, and perivascular inflammatory infiltrate. After an incubation period of 7 to 14 days, abrupt onset of fever, headache, and malaise. Symptoms increase in severity for several days. Between days 4 and 7, a rash develops that comprises of crops of pink macules on trunk and spread centrifugally but spare face, palm, and soles. During second week, the rash turns deep red or frankly purpuric. This is primarily a macular rash. Now this is the purpuric rash. Complications and comorbidities: involvement of myocardium and CNS, gangrene of finger, toes, genitals, or nose. Untreated, 40% of cases are fatal, but serious sequelae are unusual in those who recover. First-line therapy is doxycycline, given in BD dose for 7 days. Alternates are chloramphenicol, which is recommended for Rocky Mountain spotted fever. General supportive measures are needed. Isolation and effective delousing is necessary. Then Brill, Zinsser disease or sporadic typhus. This is a recrudescence of epidemic typhus, sometime after as many as 40 years. Clinical features are those of primary attack, but it is milder and less often with a rash. Murine typhus. The parasite is Rickettsial museri and spread by the rodent reservoir and caused by rat flea Xenophila chiopsis. Incidence is highest in Central and South America. Pathological changes are similar to epidemic typhus, that is involving the endothelium. Clinical features also parallel with epidemic typhus, but are milder. Rash is sparse and seldom hemorrhagic and gangrenous, and other complications are rare. Recovery occurred during second week in all but 1 to 2% of cases. Rocky Mountain spotted fever, acute febrile illness that is associated with an exanthum, seen in Rocky Mountainous areas of North America and Maryland, Virginia, North Carolina, Mexico, Colombia, and Brazil. Any age and both sexes. Most virulent of the Rickettsial infection, characterized by widespread inflammatory and destructive changes in the blood vessels, especially of skin and CNS. Organism is Rickettsia, transmitted by ticks. Incubation period 2 to 14 days, with a short malaise and headache followed by fever that is high grade 39 to 40 degrees. This is a maculopapular or hemorrhagic rash, seen mainly on the limb and trunk. Palm and soles are involved, and sometimes the rash becomes hemorrhagic and confirmed. Complications include gangrene of finger, toes, and genitals and nose due to vascular occlusion. Diagnosis is confirmed by DIF detection of Rickettsii antigen, and PCR-based tests are available. Treatment is with tetracycline or chloramphenicol, and without treatment, mortality is 20%. Tick fever or Mediterranean fever. It's a febrile illness accompanied by exanthema often preceded by inoculation from, again, a tick bite. Disease is caused by Rickettsia conuri, and Ixodes tick is the vector. Variety of different manifestations that include lymphadenitis, both sexes, any age. The pathological changes usually follow Rickettsial pattern. After an incubation period of 5 to 7 days, there is fever accompanied by headache, malaise, joint and stomach pain, and mental confusion. Fever is 39 to 40 degrees, lasting for 7 to 14 days. In some 80% of cases, onset of fever coincides with the development of an ulcer called as tachynory at the site of the tick bite. Ulcer is 2 to 5 mm in diameter with black necrotic center and a red areola. Regional nodes are enlarged and tender. 3 to 4 days later, generalized pink maculopapular eruption develop involving face, palm, and soles that increase in density for few days, and several cases the rash turns hemorrhagic. Diagnosis is confirmed serologically or by PCR. Complication is digital necrosis and pneumonia. Treatment apart from weakness and lassitude, convalescence is uneventful and recovery with doxycycline is usual, except in severe form and in frail and elderly people. Rickettsial pox. Rickettsia acari is a parasite of human mouse, and a mite transmit this disease. Both sexes, both genders. Both sexes, all ages. Vacuolar degeneration in basal layer result in blurring of dermoepidermal junction and vesiculation best regarded as subepidermal. Incubation period 7 to 14 days. Papule appear at site of the mite bite, enlarge, become vesicular, dries and form crust. Regional nodes are enlarged. After initial illness, influenza-like constitutional symptoms persist for 4 to 5 days. Onset is accompanied and soon followed by generalized eruption of papules surmounted by vesicles with crust and heal in few days. DD is atypical varicella. Rickettsial pox are papules surmounted by vesicles, while in varicella there are no papules. Illness is mild and recovery is complete. Laboratory confirmation is Western blot or by PCR. Then the typhus is the scrub typhus. Infective agent is Orientia susugamushi, previously known as Rickettsial susugamushi. And the reservoir is a rodent and caused by bites of mites. Widespread distribution in Far East and Southwest Pacific. Pathological hallmark is vasculitis involving skin, lungs, heart, brain, and kidneys. Incubation period is 10 days average, and disease starts with fever, headache, and conjunctivitis with development of primary lesion. And a primary lesion is an eschar, which is a firm papule up to 1 millimeter surrounded by a vesicle that dries to form a crust, and regional lymph nodes are enlarged. Like this. There is a papule with a central crust, thick crust. After about a week, generalized macular or maculopapular eruption develop, which fades in 7 to 10 days. Disease course and prognosis. Pneumonitis and myocarditis are frequent. Without treatment, mortality sometimes reaches 60%. The disease is confirmed by indirect immunofluorescence and treatment with doxycycline. Then comes actinomycosis. Actinomycosis is spreading suppurative granulomatous disease resulting in draining sinuses and discharging characteristic sulfur granules. Infection is caused primarily by Actinomyces israeli, and the bacteria produce filamentous branching hyphae. Most of the pathogenic actinomyces occur in nature, belong to soil saprophytic flora. Pathogenic anaerobic actinomyces are normal inhabitant of human mouth, and actinomycosis is therefore acquired endogenously after dental extraction. The disease has high incidence in rural tropical areas and agriculture workers, partly due to poor dental hygiene and poor access to antibiotics. It occurs at any age, but rare under 10 years. Adult male are more frequently affected than adult female by obvious traumatic trauma exposure. In tissue, the organism forms granular colonies which radiate delicate mycelial filaments, the splendidly Hoploff phenomena. Surrounding the colonies is chronic neutrophilic and lymphocytic infiltrate, and surrounding this there are granulomas. High power view of the colony. If we do a this stain of gram-positive stain, you can see the gram-positive bacterial rods at the periphery of the granules. Actinomyces affect all organ and tissue of the body. 5 main clinical types: pelvic, which is seen in 56.7%, cervical, facial or lumpy in 22.3%, then thoracic, abdominal in 15%, and primary cutaneous is rare. So the cervicofacial, which is second commonest, present as dull red indurated nodule on the cheek of submaxillary region, multiple sinuses. You can see the sinuses in the picture. Puckered scarring and formation of new nodule produce an uneven lumpy surface. Characteristic sulfur granules may be found in the discharging pus. Primary lesion is usually in mandible or maxilla. Probably arise as direct extension from a periodontal abscess formed as a result of the carious teeth, dental extraction, or trauma to the jaw. Periostitis, osteomyelitis, and cystic spaces develop in the bone. Induration is felt in the skin as very hard or board-like. Thoracic actinomycosis, lungs are affected as a result of aspiration of actinomyces from the mouth, and the organism tend to extend outward from the lung to the skin through thoracic wall and multiple draining sinuses. Abdominal actinomycosis begin as appendix or cecum and slow growing mass with constitutional disturbance. Organism extend into abdominal wall with the resultant sinus tract appearing on the skin. Pelvic actinomycosis is most common, associated with use of intrauterine contraceptive devices. Skin is not affected in pelvic actinomycosis. Regional lymph nodes is usually enlarged. Multiple sinuses are present at the lateral malleolus. Yellow granules or sulfur granules may be seen extruding out. DD is tuberculosis, syphilitic gumma, osteomyelitis, liver abscess, and other cancers. Cervicofacial or cutaneous varieties may remain localized for a long period. Diagnosis is established by identifying granules in the pus and histology. When crushed and examined microscopically, narrow bacillary form with elongated hyphae with occasional branching may be seen. Diagnosis should be confirmed with culture. Secondly, histopathology must be done in all cases. Management. Actinomyces israeli is sensitive to sulfonamides, streptomycin, penicillin, chloramphenicol, tetracycline, rifampicin, and erythromycin. But high-dose long-term penicillin is the usual therapy of choice. In severe cases, 10 to 12 million units of penicillin a day is given for 12 hours, given 12 hourly for 30 to 45 days, followed by wide surgical excision, and then 2 to 5 million units of penicillin intramuscular for 12 to 18 months. In an average case, daily intramuscular penicillin in a dose of 1 to 6 million unit for a period of 6 to 8 months have been employed. Nocardiosis. This is acute to chronic suppurative disease caused by an aerobic actinomycetes called as nocardia. Primary infection is usually pulmonary. CNS is frequently attacked. Primary cutaneous nocardiosis as well as mycetoma due to nocardia species are both well described. Nocardiosis of skin manifests in healthy individuals but is increasingly seen in immunosuppressed. Causative organism is Nocardia steroides, Nocardia brasiliensis, and Nocardia otitis caviarum. And they are isolated from the soil. There is a general agreement that infection is therefore exogenous, for example, for inhalation of contaminated dust. Nocardia species can cause localized skin infections, presumably after implantation. Generally present with single or multiple abscess, any sex, although rare in childhood and both genders. Clinical picture: rapid onset of febrile illness and widespread infection. The systemic nocardiosis pictures simulate pulmonary or meningeal TB. Spread to skin and subcutaneous tissue produce solitary or multiple abscesses, may involve bone and muscle. Prognosis of disseminated nocardiosis without treatment is poor. In primary cutaneous, the resolution is usual. Pus or sputum smear is examined after staining with Gram or AFP techniques. For narrow branching hyphae, which are only partially acid-fast, culture is obtained on seborrheic medium. Treatment is usually cotrimoxazole. Alternates are penicillins, minocycline, amikacin, cefotraxime, linezolid, and imipenem. Dermatosis that are possibly attributed to bacteria. That include chancroform pyoderma. Condition is seen in children than in adults. It's a necrotizing reaction to Staph aureus, which is inoculated after minor trauma. Lesion is solitary, usually around eyes, mouth, or genitals. There is sharply marginated ulcer, sometimes exceeding 1 centimeter, with indurated base and bright red areola. Regional nodes enlarged. DDR epithelioma, syphilis, primary TB, accidental vaccination, swimming pool granuloma, and leishmaniasis. Without treatment, ulcer persists for several weeks before healing to leave superficial scar. Treatment with antibiotics shorten the duration, but response is not dramatic. Pyoderma vegetans. Condition of uncertain etiology, characterized by development of epithelial hyperplasia and chronic granulomatous changes, crusting sinus tract formation and ulceration, most commonly by staph or group A strep. But as the rash does not respond to antibiotic, role of these bacteria in pathogenesis is unclear. It is associated with inflammatory bowel disease like ulcerative colitis, alcoholism, lymphoma, and severe psoriatic arthritis. It develops at any site, but flexures are often involved. The pustule fringe variety called as the Pyodermide vegetanti of Halopio is described in association with ulcerative colitis. In some cases, encrusted hyperplastic plaque develop, they break down and weep, and there may be ulceration and condition resembling Pyoderma gangrenosum. In Pyodermide vegetanti, crusted plaque containing pustules are described in multiple sites from flexures to the scalp. So this is how the lesions look like. Oral lesions may also occur. Lesions heal spontaneously, but generally this is a chronic disease and important to exclude underlying disease like ulcerative colitis, lymphoma, or leukemia. Differentials: iododerma, Pyoderma gangrenosum, pemphigus vegetans. Management: poor response to antibiotic alone. So topical and systemic corticosteroid appear to produce some response. And there is a report of excellent response to etanercept in patient who had psoriatic arthritis as well. Dermatitis gangrenosa infantum, a rare condition in infants in first 2 years of life, present as multiple necrotic ulcers. A condition arises de novo and appear on pre-existing rash such as varicella or severe seborrheic dermatitis. Affected children usually gravely ill with high pyrexia and rapid deterioration, ending in death. It's a form of infantile Pyoderma gangrenosum. Secondary complications are septicemia dominate the picture. Staph aureus are isolated. Kawasaki disease, this is the last heading. This condition or the disease is seen in children, often those less than 2 years, and present as fever and generalized exanthum. Complications include myocarditis and arthritis. Etiology unknown, although recent evidence suggests the role of bacterial superintelligence as a possible trigger factor. Males are more commonly affected and condition is seen more often in siblings. Therefore, epidemic of disease has never been reported. Pathogenesis. There is a recent evidence that certain subtypes of T lymphocytes V beta 2, V beta 8 are stimulated, suggesting activation of superantigens, toxic shock antigens from both staph and strep. These cause diseases through wide-scale activation of immune mechanisms, especially vascular endothelium. The major complication is development of small aneurysm of coronary arteries, secondary to vasculitis centering on these vessels. Onset is acute with high fever for 5 to 7 days. Then oral mucosa and conjunctiva are injected, lips are dry and fissured, and tongue appear red with prominent papillae, the strawberry tongue. After 3 to 4 days, there is widespread morbilliform eruption that get localized over hands and feet with edema that is followed by scaling which starts over the digits. There is accompanying cervical lymphadenitis in many patients. Fever resolves after 1 to 2 weeks, but conjunctival infection and lassitude may persist. In about 1/4 of the cases, there is accompanying myocarditis and symptomatic coronary artery disease. Myocarditis present with arrhythmia and tachycardia, pericarditis, and valve incompetence. However, the lesions regress over a couple of years in most patients. So these are signs and symptoms of Kawasaki: the conjunctival injection, the dry and cracked lips, the strawberry tongue, peripheral peeling, cracked lips, and peeling of skin from hands and feet. The complications are coronary artery aneurysm. There is peeling of skin around the fingers, scaling or erythema, red eye, dry red cracked lips, and inflamed tongue. The typical rash and short-term fever. Other complications beside myocarditis is arthritis, severe EM, iritis, proteinuria, hepatitis, and aseptic meningitis. There will be leukocytosis and thrombocytosis with raised ESR. No specific diagnostic test. Presence of typical rash and accompanying myocarditis are common. Management. There is no definitive treatment for Kawasaki disease. Intravenous gamma globulin in a dose of 2 grams per kg in a single infusion over 10 hours is very helpful and reduce overall mortality and complication of the disease. Aspirin is helpful in reducing the platelet aggregation and is used as a short term in most patients and long term if there is evidence of coronary aneurysm. This ends my talk today, and hopefully see you after the conference with another edition of my lecture. Thank you and goodbye and have a nice day.